privilege of introducing Dr. Richard Furman, renowned WM expert. Welcome, Dr. Furman. Thanks for making time for us today.
Oh, my pleasure. Thank you all for having me.
What a total thrill. Dr. Furman is director of the CLL Research Center at Weill Cornell Medicine and a member of the Lymphoma Myeloma Service in the Division of Hem-Onc. His area of focus is on the development of non-chemotherapeutic approaches to treating CLL, and he's played an integral part in the development of both ibrutinib and idelalisib, located not far from the Frick collection. Am I right where your office is? I think
actually,
a group trip. No? Am I wrong? Have you moved?
No, it's actually only about half a mile.
I know, right? In New York, that's nothing. I was thinking we could go have lunch. We do a group trip. We go to the Frick. We see Dr. Furman. No?
I was probably there once 10 years ago. That's half a mile is quite far in New York City.
Oh, stop. That's nothing. Oh, my goodness. We're real out-of-towners. You can tell, right? We're real out-of-towners. Well, I want to share a fun fact with you all about Dr. Furman. When you talk to any of Dr. Furman's patients, all of the WMers have one thing in common other than WM. They have a starry look in their eyes and a very warm smile and a certain kind of fandom when talking about their favorite doctor. And if you've spoken with anyone, you know what I'm talking about. His innovative approach, fresh perspective, and outside the box thinking are coveted traits and really most revered. So here's what we're looking forward to during our time together with Dr. Furman. We're going to learn more about his exciting work in the world of WM, and I want to thank you for submitting so many fascinating questions, and I want to thank Dr. Furman for entertaining so many questions that we kept shooting your way. We're also going to discuss how the COVID vaccine might impact WM patients, and lastly, we're going to ask Dr. Furman to answer the critical question that we ask of every WM rock star, which is, what is the one thing that you wish every WMer knew today? So we'll, at the end of the call, ask Dr. Furman, we'll remind you to tell us what you think that one thing should be. So Dr. Furman, what we have here today are 40 folks from across.
Can I start with the end though?
Oh yeah, that's awesome. And I want you to know we've got like 40 people here across North America who represent support groups. We put their name and their state, and the ones in Canada, you can see where they are from in Canada, all up there, so you can get a sense of the widespread we have here, and every one of them is representing their group. So they're going to share this answer that you're about to share with us with all of their groups and beyond. So we're all ears. Tell us.
No, so I really do think that, and this is something that, you know, I do believe that one of my greatest jobs in my role as an oncologist is to really be a cheerleader. I mean, we have great therapies and great options for patients, and my job really is to keep the patient, you know, sane together and get them through everything. What I really think I'd like every Waldenstrom's patient to know is that being diagnosed in 2021, you know, my hope and my expectation is that maybe we can actually expect a normal longevity for all Waldenstrom's patients. And I think that's really key. I mean, you had mentioned idelalisib and ibrutinib, but in actuality, I mean, so idelalisib was the first novel agent that we really had. There were a few before that. Fostamatinib was actually one that never really made it in lymphomas, but it was a very effective therapy as well. There was also Venetoclax. I mean, there were a tremendous number of agents before then that, you know, were just less effective that people haven't really heard about. So, you know, this is something that I've really been doing for the last 25 years. And it's really been, you know, since idelalisib, ibrutinib, and, you know, I've been involved with Acalabrutinib and Venetoclax and Zanubrutinib and umbralisib and duvelisib. All these new agents really just offer such a tremendous array of different treatment options for patients. So I really, you know, I today made a lot of slides, and I think you're going to have to let me know if you prefer me to speak to the slides or just take questions and discuss, you know, what all questions that you may have.
Interesting question. Okay, thank you for that fascinating answer. And how much do I love the longevity answer? So thank you, Dr. Furman.
Yes.
Like, what an amazing message, to a hopeful one with a lot of promise behind it that will be very meaningful, I know, to WMers worldwide. So I'm very grateful for that. And I definitely want to turn the floor over to you. I'm just wondering, should we poll the group, folks, in terms of slides versus questions? I know people sometimes, enjoy a formal presentation, but also love the opportunity to speak. Should we ask people to weigh? What do you think?
So let me start with the slides, and I'll try to leave plenty of time in the end.
I love it. Thank you, Doctor. We're so grateful you're here. I'm going to mute myself so that you get the whole floor, and I want to thank you for all that you do for WM patients worldwide.
Thank you. So can everyone see my my slides?
Yes.
Yes.
I don't know if you're seeing the right view. Are you seeing just my?
No, I don't think you're in presentation view just yet.
Yeah.
We're seeing on the left, we're seeing your slides on. Yeah, there we go. Now you.
Good.
Okay. So that was actually the last slide. All right. So I thought really what would be very important, very helpful, were really just to sort of start with a overview of Waldenstrom's, because I know the question, one of the questions that I was asked was to sort of address, what are those questions that every, director of a Waldenstrom's group should really know. And so I think really understanding how Waldenstrom's fits into our hierarchy of lymphomas is always the best place to start. All right, so I thought I'd start talking about what we call lymphoma ontogeny, which is really just sort of, how these lymphomas all relate to one another. Talk a little bit about the diagnosis, the clinical course, and then some therapy. So this really is, it's a very old slide, as you can see, from 1998, but the frequency of lymphomas really hasn't changed much in all this time. We've certainly seen an increase in lymphomas as the population has aged, because a lot of our lymphomas, a lot of our non-Hodgkin's lymphomas really do have greater incidence in older patients. What I like to always sort of start out with is each year in the United States, there's about 80,000 lymphomas. And lymphomas really are the fifth, or actually now the sixth, most common cancer in the United States. Lung, prostate, and breast are going to be 1, 2, and 3. And they're in the range of 225 to 250,000 cases. So that gives you sort of a marker of what's a common cancer. Lymphomas being 80,000, of course, is far fewer. But of course, 5,000 of the 80,000 are going to be Hodgkin's disease, and the remaining 75,000 are going to be non-Hodgkin's. And then the non-Hodgkin's lymphomas are divided into about 65 different subgroups, of which Waldenstrom's or lymphoplasmacytic lymphoma is really one subgroup. And overall, there's about 1,500 new cases of Waldenstrom's a year in the United States. So we're talking about, when you compare to a lung cancer, 250,000 cases a year, Waldenstrom's are talking about just 1,500. And that's sort of the perspective that I think is important to keep in mind. Obviously, this is a rare and special disease, and so all of you should appreciate how rare and special each of you are. And I think that it's sort of interesting because people talk about lymphomas in groups, but non-Hodgkin's lymphomas are really so heterogeneous, and we divide them into indolent and aggressive, with the indolent being CLL, marginal zone lymphoplasmacytic, follicular lymphoma, and the aggressives being diffuse large B-cell lymphoma, a lot of the T-cell lymphomas, mantle cell lymphoma. But even within the indolent non-Hodgkin's lymphomas, Waldenstrom's is very unique and really demonstrates very different clinical behavior from the other types of lymphomas. And I think that's really something that is often not understood by a lot of clinicians in the community. So when we look at lymphomas, the way I like to describe them is that, and can everyone see my pointer? Okay, so, the way we look at lymphomas in 2021 is that each lymphoma represents a normal stage of B-cell differentiation where the cells sort of get stuck. And as they get stuck, they accumulate at that stage, and that's the lymphoma. So normally this is a naive B cell, which is a B cell that hasn't yet been exposed to its target, what we call antigen. This B cell leaves the bone marrow and will just circulate in the blood, the bone marrow, the lymph nodes, and the spleen and wait until it meets its bacteria or virus that it's pre-programmed to respond to. And then when it sees the virus, it actually goes to a germinal center reaction where it really becomes what's called a centroblast, which is a rapidly dividing and growing B cell to make a lot of copies of itself. And then it differentiates into a centrocyte, which is a cell that's no longer dividing, but one that's really having the fit of its antibody being tested by the immune system. So this naive B cell makes one antibody, and then it goes into this germinal center reaction where it will randomly mutate and change the antibody to make a lot of different antibodies that are close but slightly different from that original antibody. And this is how the body develops diversity of antibodies. And then, some of these antibodies will be better fit for the target, and they'll be rescued, and the ones that are induced to continue to grow and divide. And they'll either become plasma cells, which make antibodies, or they'll become memory B cells, which basically hang out for the next time. And at each stage in differentiation, you can see we have corresponding lymphomas. So if it's a centroblast, it's going to be either a diffuse large B cell lymphoma or a primary mediastinal lymphoma. If it's a naive B cell, it's going to be maybe a CLL. If it's a memory B cell, it'll be a splenic marginal zone or a MALT lymphoma. If it's a naive mantle zone B cell, it's going to be a mantle cell lymphoma. So this is how the lymphomas really get their name and how they're all related to one another. Now, lymphoplasmacytic lymphoma, Waldenstrom's, is listed here. It's actually a little bit different. And what we have is that this whole process can take about 2 weeks from the time a virus or bacteria gets into the blood until that naive B cell becomes a plasma cell and start making ample amount of antibodies. So we have and I'm assuming everyone can hear me okay. I didn't even check my sound beforehand. So the immune system's evolved a scenario where it will take that naive B cell and bypass everything and just start making a lot of IgM antibodies. And these IgM antibodies are made typically within 3 to 4 days and are a little bit of a crude antibody. So they don't have a great fit. And I'll talk later as to how the IgM antibody makes up for that. But it's really what we call lymphoplasmacytic cell. And it really is what becomes the Waldenstrom cell. And that IgM has different features and characteristics to enable it to make up for having a poorly avid antibody. But those are also the features that actually create sort of the clinical sequelae of Waldenstrom's macroglobulinemia. So here's the diagnostic criteria for Waldenstrom's. I'm really not going to spend a lot of time on it because I think, a lot of this is not relevant, except to say that, the hallmark of all lymphomas is really homogeneity. So if you're looking at a lymphoma patient, every cancer cell is going to be basically a daughter cell of one cell, and really will be identical genetically and morphologically. But in Waldenstrom's, we have a very, very unique situation where you end up with a lymphocyte that will also have plasmacytoid lymphocytes and plasma cells as part of the clone. And so you see a lot of heterogeneity. And that's really, I think, one of the things that makes Waldenstrom's so unique. Now, every Waldenstrom cell has a surface immunoglobulin, has an immunophenotype, which is really just an identification of the proteins on the surface. And this includes having a surface immunoglobulin, typically CD19 and 20, and most commonly CD5 negative, CD10 negative, and CD23. And the CD stands for cluster differentiation. And that's really just when a protein gets really well characterized, they actually will acknowledge its characterization and give it a CD designation. So we're right now up to about CD 350. But and these are actually, the numbers are doled out in just sort of the number of the timing of discovery, but they all have characteristic expression patterns. So CD19 and 20 are really on all B cells. CD10 is actually on 2 subpopulations of B cells. CD23 can be on a lot of activated B cells, but also on macrophages and dendritic cells. And so based upon how we look at these different markers, we can actually characterize the cells and actually help define them and really create what we want, which is a sort of a very homogeneous population of clinical cases when we call them one diagnosis. And what I want to show you here is sort of what we have with Waldenstrom's, which is we have a mixture of lymphocytes. So this is what a normal lymphocyte might look like, which is mostly nucleus with scant amount of cytoplasm, right? So a small amount of cytoplasm and then the nucleus here. We'll have lymphoplasmacytoid lymphocytes, where you'll have the nucleus actually a little eccentric and what's called a Golgi apparatus, where the antibodies are being produced. And then you can have real plasma cells. And this is what makes Waldenstrom so unique, because something like CLL would be just these cells again and again and again, just a lot of identical appearing cells. But in Waldenstrom's, you have these three different cell types all mixed into the malignant clone, and that's what really makes it so unique. And here's just another picture to show you some of the differences. So what are the presenting signs and symptoms of Waldenstrom's? And I listed them here. I mean, as you can see, they're very, very non-specific. And this is actually data that was published by the Mayo Clinic back in 2000. I would like to point out that, you know, these are not really the presenting signs and symptoms that we would see in 2021. You know, in 2021, most of the patients present with either having a high total protein or a high globulin on their routine lab test. And someone says, oh, your total protein is 7.5, you should go see a hematologist. And then we do an immunofixation electrophoresis, and we see, oh, you have a high protein. But there are times that people will present with interesting aspects. So the one thing I do see very commonly nowadays are people is people presenting with peripheral neuropathy. So someone has neuropathy and goes see the neurologist, and the neurologist will check the immunofixation electrophoresis and say, you have a monoclonal IgM protein. Yes, that's causing your neuropathy, but now you got to go see a hematologist. So most of the time now, people are presenting with lab abnormalities. After the lab abnormalities, I'd probably say that peripheral neuropathy is going to be the most common presenting symptom nowadays. And that's sort of relatively important because it really is sort of a very, as you can see, you know, it's a very eclectic collection, if I may, of different signs and symptoms. So this is what I think really is the big crux of everything. You know, most lymphomas basically cause symptoms by just having the cells take up space. And when they take up space in the bone marrow, they interfere with the normal blood making. And so you become anemic, which is a low red cell count, and thrombocytopenic, which is a low platelet count. You can get lymph node enlargement just from the cells occupying the lymph nodes. You can have the cells fill up the spleen and get splenomegaly. Or you can, in CLL, even have the cells fill up the blood and you can get a lymphocytosis. But Waldenstrom's really, because of this IgM production, really sets patients up for some unique sequelae. So one is the IgM, which is the protein that's the antibody, can have an impact on the blood viscosity, and it can actually activate the immune system. So when it has an impact on the viscosity, it can cause, you know, cerebral vascular accidents or strokes, retinopathy, and then vasculitis, which is just from basically activating the immune system non-specifically in the blood vessels. The IgM can bind targets as well, because remember, all antibodies are directed against some target, hopefully bacteria and viruses, but very frequently autoantibodies. And so we can see the IgM bind to nerves and cause neuropathy, or bind to red cells and cause cold agglutinin disease. And then, of course, the Waldenstrom's does what all other lymphomas do, which is just take up space and cause anemia, thrombocytopenia, splenomegaly, and lymphadenopathy. And this is just a picture of retinopathy, just to remind me to tell everyone to make sure everyone have their eyes checked. You know, it's an important aspect of, you know, health maintenance. You know, when we talk about, you know, one of the important questions that I always wonder about is that we often see problems of viscosity occur in patients when they have IgMs greater than 5,000. Nowadays, you know, what I think is going to be the very important question is, what about that person who walks around with an IgM of 1,000 for 25 years? Is that going to lead to any problems? And, you know, listen, that's a question that's now relevant, which is wonderful, because we now, with our new therapies, can have patients ostensibly walk around with IgMs of 1,000 for 25 years. And so we don't know that answer, but that's one of the questions that I think we need to answer going forward. One of the things that I think is also important is the idea that, you know, everyone's IgM antibody behaves a little bit differently. And the impact of the IgM on the serum viscosity is really dependent on the chemistry of the antibody. So you'll see that there's definitely a correlation between how much IgM is there and the viscosity, but some people's IgMs will have a much bigger impact than others. The other thing that I think is really important is serum viscosity is a very hard assay to measure. And so I actually follow the IgM itself, then not the viscosity, just because that's really a much more accurate measure. Now, one of the questions I always get is the differences between an M protein and a quantitative IgM. In an M protein, the M stands for monoclonal. It doesn't stand for IgM. And it's just an unfortunate mischaracterization. But it's really generated by having a pathologist look at an electrophoresis where they basically take the serum proteins, they run them on a gel and separate the proteins by size and electric charge, and then stain. And they look for a band, basically a large number of proteins that are all identical in size and charge that will then run on one spot. And that's called a monoclonal protein. And they'll actually estimate the size of the M protein using optical scanning. That's very different. And you'll get an M protein that might be, 2 grams per deciliter or 2 milligrams per deciliter. I'm sorry, 2 grams per deciliter. But that's very different than what's called nephrolometry. Well, they'll actually measure the amount of IgM, and the IgM, may get measured out at 2,500 milligrams per deciliter. And I think this is important because the 2,500 milligrams per deciliter might correspond to an M protein of 2 grams per deciliter. And the question is my tumor spike going to be 2,500 or is it going to be 2,000? And the answer is that normally your IgM should be somewhere between 30 and 300. So anything above 300 has to be basically, Waldenstrom's protein. And so if someone has a total IgM at 2,500, you know that you have at least 2,200 milligrams per deciliter of Waldenstrom's protein. Most of us just use the quantitative IgM because it's really much more accurate. Now, what I gave you were 2 very close representations. Most of the time, a patient with an IgM of, say, 4,500 might have an M protein of 2,500. So the differences can be really quite broad. And a lot of that is just because of the differences in sensitivity of the assay and the need for the pathologist to eyeball sort of what's monoclonal protein versus not. And then I just wanted to show you this about the cryoglobulin, because this I find very interesting. So everyone has cryoglobulins, and a cryoglobulin, simply defined, is just any protein in the serum that precipitates at 4 degrees. So the serum is basically the liquid part of the blood minus the clotting factors. And that's what you see here on the right as a yellow straw-colored fluid. Now, when you cool it, a lot of the times you'll see protein precipitate, and that's what you see here. And that protein that precipitates is called the cryoprecipitate. Now, cryoglobulins and cryoprecipitate are really the, so yes, so that precipitate is what we call a cryoglobulin. We then spin it down and get what's called a cryocrit. Most people will have cryoglobulins at a very low level, maybe 1 to 2%, but because they're only precipitating at 4 degrees, and physiologically we all exist somewhere between 35 and 37 degrees, they're never clinically relevant. The people who have symptomatic cryoglobulinemia are those whose cryoglobulins precipitate at 35 degrees. And that would be sort of the fingers and the toes. And we do see that in Waldenstrom's. But what we see much more commonly, which I really want to try to emphasize for people, is that the IgM itself might precipitate at 27 degrees, in which case it's not physiologically relevant that it's precipitating, and it won't behave like a cryoglobulin. But if you draw someone's blood and it sits on the countertop waiting for the courier to pick it up and then take it to Quest Diagnostics to run it, it is possible for that antibody to precipitate out, and when they go to measure the IgM, not to see it there. Now, I want to assure everyone that this is not that common, but it is something that I think everyone should have evaluated at diagnosis. So I had one patient walk into me for an evaluation of an Waldenstrom's, and he basically had a hemoglobin of 7 that led to the bone marrow biopsy that showed the Waldenstrom's, and he had an IgM protein of only 300. Now, he actually described classic symptoms of claudication. So he basically described claudication as where with repetitive motion, your muscles fatigue. So he had trouble, his legs would get tired from walking short distances. He even described his jaw muscles becoming tired from chewing his food. And so I ran his IgM warm, and it turned out to be 12,000. And so the issue really was that, when the local oncologist sent the blood to Quest, it's going to sit there and precipitate in transit. Whereas for me, I'm able to actually take the blood, keep it warm, and run it right upstairs and run it immediately. So that's one of the advantages of being in the hospital. So that's why I just always caution everyone to have it's only going to be really relevant when people have very, very high IgMs, but it is something just to keep in mind. Unfortunately, it's rare, but it is sort of, I think, an interesting feature. Importantly, though, this cryoglobulin that this patient had, was not clinically relevant because, it didn't precipitate out at 35 degrees. It precipitated out at room temperature, but in the patient himself, it never precipitated out. So we didn't have the issues of a cryoglobulinemia, we just had issues of a very high IgM. And that's an important distinction. So what makes the IgM so unique? So what I have here on the left, this is an IgG antibody. This is actually it's actually what all antibodies look like as monomers. And an antibody is made up of a heavy chain and a light chain. Well, 2 heavy chains, which are identical, and 2 light chains that are identical. And the one light chain's paired to a heavy chain, and then the 2 are paired together. And what we have are 3 constant regions and 1 variable region in the heavy chain, and 1 constant region in the light chain, and 1 variable region in the light chain. And this variable region is what changes with every antibody that makes the antibody have different specificities. Now, an IgG exists as a monomer. Now, there are subtle differences in the heavy chain between these different antibodies. So an IgM, as it turns out, has 1 more constant region, so it's 4 constant regions. But what really makes the IgM different is the effector functions that are down here in the constant regions. So this IgG antibody is very good at binding its target and then binding to an FC receptor that will activate a T cell or a macrophage or some immune effector cell. But the IgM, because this part of the antibody here doesn't have the time or the ability to undergo the refinements that most antibodies do, has adapted to make up for it by having some additional activities here. So on the one hand, the IgMs exist as a pentamer. So you can see here we have 5 of these antibodies fused together at the base, and this is a pentamer. And so on the one hand, even though each one of these areas binds a target weakly, because we now have 10 binding sites together, we've amplified the ability for the antibody to actually grab on. And that's the first thing the antibody does to make up for its poor avidity. The second thing it does is it's very good at activating complement. And that's based upon the FC portion down here. And what complement is a protein that actually gets activated and then adheres to whatever target it falls on. And it will basically signal to the immune system to destroy this target. So when this IgM falls onto for instance, a bacteria in the fingers, because it's 35 degrees in your fingers, the IgM is able to bind, because it's easier to bind at colder temperatures because there's less energy in the system to overcome. The IgM antibody will then activate complement. Complement will deposit on the cell, on the bacteria. The antibody could fall off them, but because the complement's on the bacteria already, the immune system knows to target that bacteria and will then go ahead and eliminate that bacteria. Now, this is actually, obviously a great thing. The problem, of course, is that if the IgM were to accidentally bind to a red cell, it can then deposit the complement on the red cell and lead to hemolysis or destruction of the red cells. Or these antibodies can actually fall onto the wall of the blood vessel and activate complement into the blood vessel, and that's a vasculitis. So in a way, the IgM's problem is it can activate non-specifically the immune system as well. And when you have so much IgM that's hanging around, that sometimes happens as well. And so this is one of the reasons why we do see either hemolytic anemias or vasculitises, even like what's called livedo reticularis, or sort of the livedo rash that a lot of people sometimes have, is because of the non-specific activity of these antibodies. Now, the non-specific activity of these antibodies is also what's responsible for the neuropathy, because these antibodies are basically guessed what they should target in the bone marrow. And so a lot of these antibodies react with, they've evolved to react with what are bacterial proteins and glycoproteins that happen to be very similar to what we have on our nerves. And so you'll see these antibodies also cross-react with our nerves and cause neuropathy by demyelinating the nerves. And so that's what's responsible for, when we talk about the IgM causing neuropathy or hemolytic anemia or vasculitis, because of this non-specific activity of the IgM.
Dr. Furman, I
Yes.
was just wondering if we might be able to, just because folks have been listening for a bit, if there's any questions that anybody might have, or just check in. And I don't know where we are in your slide deck. I know that folks are excited with all their questions as well, but that you might want to do afterwards. But I thought in case there was anything that folks had were wondering about midway through.
Absolutely interrupt me. Does anyone have any questions so far?
Any questions or thoughts? I know everybody's anxious to learn more, but I just wanted to do a time check with you. Thank you so much, Dr. Furman.
Of course.
I have
So let me then I'll go through a little bit quicker.
Oh, we have one question that just popped up.
Yeah. Hi, this is Sue. I just have a question about the hemolytic anemia and how often do you see that occur?
We actually don't see it that commonly. It's sort of a very rare phenomenon. It can happen in 2 ways: cold agglutinins and basically, what we call is it's a cold-mediated autoimmune hemolytic anemia. It is sort of rare. It's interesting because we do have a couple of new therapies that can actually help treat it. Of course, treating the Waldenstroms is also very effective for it, but it is fairly rare.
Thank you.
So I just want to remark that, neuropathy really is quite common. And interestingly, even patients who don't have neuropathy seem to be more sensitive to all of our treatments that have neuropathy as side effects. So we did a trial years ago using thalidomide in Waldenstrom's, and in CLL patients, thalidomide caused neuropathy maybe about 5 to 8% of the time. We had a 100% response rate in our trial, but we also had a 75% rate of neuropathy. And so obviously the treatment, while effective, was certainly not tolerable. And these were people who entered the trial without having neuropathy. So it was clear that they were more sensitive to developing neuropathy on thalidomide, which is one of the known side effects of thalidomide. And these are actually autoantibodies directed against the myelin, the sulfatide or ganglioside proteins on the myelin itself. One of the things I think that often gets misrepresented is the fact that not all people with a high IgM actually have Waldenstrom's. And any lymphoma can actually be associated, and that includes CLL, with an IgM monoclonal protein. And you'll often see the pathologists talk about a diagnosis of lymphoplasmacytic lymphoma, and the hematologists talk about Waldenstrom's. And what's important is that we think of Waldenstrom's really as a clinical entity where you have a very high IgM and lymphoplasmacytic cells in the bone marrow. You can have lymphoplasmacytic cells in the bone marrow that make an IgG, or you can even have a marginal zone lymphoma that makes an IgM that might be about 2,000. But distinguishing that from Waldenstrom's is important because the truth is marginal zone lymphomas rarely go above 2,000 milligrams per deciliter of IgM, whereas the lymphoplasmacytic lymphomas that are Waldenstrom's, you'll actually see the IgM continue to rise, without end. And so it's just a very interesting difference between the two of them. So I just have this here just to remark, while we're talking about the IgM, people can have neuropathy called agglutinin disease, cryoglobulin disease, all due to an IgM without actually having Waldenstrom's. And so that's something very important. So I'm just going to quickly talk about treatment options because I know a lot of you had very specific questions. This is just broad categorization of all the different treatment options. And I'm actually happy to circulate my slides, so you don't have to take notes on all of this. But what I really want to remark on is the NCCN guidelines, which I never really found very helpful, really just sort of list everything. And you could see here that preferred treatment regimens for treatment-naive Waldenstrom's include bendamustine rituximab, bortezomib, dexamethasone rituximab, ibrutinib with or without rituximab, or rituximab, cyclophosphamide, and dexamethasone. And then you can see perhaps everything else imaginable listed under the recommended regimens, the other recommended regimens. And while this is up there, I want to remind everybody that, when a drug gets approved by the FDA, it's approved based upon a trial, and the approval is going to be based for the patient population that was studied. So ibrutinib was studied in Waldenstrom's patients and approved for Waldenstrom's patients. Acalabrutinib has been approved for mantle cell and CLL. Now we have data that shows that acalabrutinib is effective in Waldenstrom's. It's just not approved for Waldenstrom's. And one of the things that I really find very important, and I'm a little disappointed in some of my colleagues, is that once a drug is approved for any reason, you can actually use it for anything that you think is, clinically correct. So I actually don't use ibrutinib anymore in my Waldenstrom's patients because I believe acalabrutinib and zanubrutinib are so much better tolerated. And so, yes, neither acalabrutinib or zanubrutinib is approved for Waldenstrom's, but that doesn't keep me from prescribing it and then often fighting with the insurance company to get approval. But a lot of the times the insurance companies just say it's a BTK inhibitor, that's fine, and we'll approve it. And it's a way to take advantage of newer drugs that might not yet be approved that are better, or for a disease like Waldenstrom's, which is really such a small market, may not have drugs being developed for it, that are still effective. And we see this with Venetoclax. So there's a trial that's not yet been published that Dr. Castile ran that really showed Venetoclax to be very effective. And so I actually have been using Venetoclax off trial in a number of my patients. And it's just a matter of me fighting with the insurance company to get it approved. And so I encourage everyone to actually, remind their physicians that these are options, even though, the NCCN guideline is sort of restricted by sort of what has an FDA label. It doesn't mean that these aren't the only options and that you can't take advantage of newer agents that are approved. In general, I actually always like to avoid chemotherapy. I think we don't know long-term what a lot of these agents, what impact they may have. We have a lot of data in CLL regarding the purine analogs, and in particular, the purine analogs mixed with alkylators like cyclophosphamide. So we know that FCR has about a 10% chance of MDS, which is a bone marrow failure syndrome, developing. And so avoiding that, I think, is really, key, because the one thing I don't want my patients to do is 10 years after having a great response to FCR, need a bone marrow transplant because they've actually had their bone marrow damaged. Now, bendamustine is an interesting agent because it's been around since 1970, but we really don't have any data, pre-2005. And so we don't have a lot of long-term data. Right now, it actually does seem to be much nicer to the bone marrow than FCR does. And so it is an agent that a lot of people, so of all the chemotherapy agents, it's the one that's most commonly used. But I still always worry, if we're going to be wondering how people's bone marrow health is in the next 10 to 15 to 20 years, I certainly want to try to avoid chemotherapy. The other issue is something like bortezomib, which can certainly cause problems with neuropathy, and we see that. Interestingly, carfilzomib and ixazomib are both proteasome inhibitors, not yet approved for Waldenstrom's, but do have a much lower risk of neuropathy. And so once again, I often will try to use those before bortezomib in my patients because they all work the same way and they all have equal efficacy based upon the studies, but likely will have fewer side effects. And then I just want to say for the previously treated, it's really just the same things all over again. So let's talk a little bit about Bcr antagonists, because these are the novel agents that I really think are going to revolutionize everything for our patients. So the first B cell receptor protein that we targeted was called the Syk protein, followed by BTK and PI3 kinase. And what we have here is the B cell receptor is really, it's an antibody molecule on the surface of the B cell that when it binds its target, transmits its signal internally through a series of different proteins that will lead to activation of gene transcription through these secondary messengers. And that really is what activates the cell. And you can see here that we have a number of inhibitors for all of these. So for Syk, we actually have fostamatinib, which was the first one and developed in 2007. It's now approved for ITP, but it is effective in lymphoma. We have the BTK, so acalabrutinib, ibrutinib, and zanubrutinib, as well as the reversible inhibitors, so vexabrutinib, LOXO305, and ARQ531, and the PI3 kinase inhibitors, idelalisib, duvelisib, and umbralisib. And all of these are called B cell receptor inhibitors because they inhibit this pathway that involves the B cell receptor. Importantly, they inhibit a lot of other pathways as well. And while we all do think the B cell receptor is probably the most important, it's unclear that it's, it in and of itself is really all that's necessary. What I do like to show everybody is that this is really what the B cell receptor signaling cascade looks like. So while we have this nice, neat diagram here, I'm actually amazed with all these redundant pathways that inhibiting one enzyme ever actually has an impact. So this is really a much more accurate representation of what the B cell receptor pathway looks like. Real quick, just to talk about ibrutinib, because it really was the paradigm. Colonel Bruton identified in 1952 a group of kids who had no antibodies in their serum. They were missing their gamma globulins. And you can see that here in the electrophoretic pattern. And in essence, they actually all died of infections. And so they were called Bruton's agammaglobulinemia. We now call that X-linked agammaglobulinemia because we know that it's an X-linked gene and they were all boys. In 1993, we identified that the gene that was missing was Bruton's tyrosine kinase. And then in 2005, ibrutinib was synthesized and targeted it. And what really I think is most important is here we have the BTK protein itself, and this is the ATP binding pocket. So normally an ATP molecule goes in here and supplies energy for the enzyme to then catalyze a reaction. But ibrutinib, acalabrutinib, and zanubrutinib all fit in this pocket and actually bind to the cysteine here. And it's binding the cysteine irreversibly that allows it to stay in the pocket and prevent ATP from getting in, and therefore irreversibly inhibiting the enzyme. And this is why ibrutinib, acalabrutinib, and zanubrutinib all work the same way in terms of their inhibition of BTK. The difference between these is sort of what other enzymes the molecule happens to fit into. So here we have the BTK approvals, and you can see here that, ibrutinib has, of course, given its age, the most approvals. Acalabrutinib is approved in CLL and mantle cell, and zanubrutinib is actually currently only approved for mantle cell. Certainly there'll be many more approvals coming in the not too distant future. Just some quick data on acalabrutinib. Here you can see that it's a very high response rate and generates a very long progression-free survival, and it's extremely well tolerated. And here's actually the ibrutinib and zanubrutinib study, which was really done to show that the two are equally effective and zanubrutinib is actually better tolerated. And you can see here on the progression-free survival curve, the curves really are superimposable. But when we look at the risk of atrial fibrillation, you can actually see here that there's actually, atrial fibrillation is up here, neutropenia is down here, that there's actually fewer episodes of atrial fibrillation with zanubrutinib than ibrutinib, which enables people to stay on the study more. Interestingly, zanubrutinib does have a higher risk of neutropenia, but fortunately that doesn't preclude people from having to actually come off drug. And then I just quickly want to talk about the side effects of ibrutinib as the paradigm of BTK inhibitors. We talk about diarrhea due to ibrutinib probably inhibiting EGFR. Fortunately, while it's very common, a lot of the diarrhea people acclimate to. People also, though, by taking the pill at night, seem to be able to avoid the diarrhea because they then have an empty GI tract overnight. And by the time they eat in the morning, their GI tract has regenerated the EGFR. Bleeding is particularly interesting because it's really due to ibrutinib inhibiting BTK and TEC. And acalabrutinib and zanubrutinib both inhibit TEC, but not as intensely as ibrutinib does at the doses we're using. So they do have less bleeding. And the same thing for thrombocytopenia. Atrial fibrillation, that's really the most worrisome side effect because it really is something that can have an impact on a patient's outcome. And it's about 15% with ibrutinib and less with acalabrutinib and zanubrutinib. And then, of course, hypertension and the nail changes, I'm sure a lot of people are familiar with, which we don't see with zanubrutinib and acalabrutinib. So my final slide, I just want to talk about COVID-19. So COVID-19, it's a coronavirus, and coronaviruses are responsible for about half of all the common colds. So we've had coronaviruses for a long, long time. They've really never been of great concern. You'll get infected with a coronavirus. You'll have symptoms for a period of time, and then those symptoms will resolve, and you'll actually be immune from that to that coronavirus for the next couple of months. Fortunately, coronaviruses are seasonal, and so you'll get that cold, you'll be immune, January, February, March, and then of course it's spring, and so the coronaviruses are no longer circulating. One of the problems we have with COVID is it's actually not seasonal, but it's year round. And so we don't know how long the immunity is going to last due to actually being infected or getting the vaccine. And so one of the important things that we need to figure out is how frequently everyone needs to be revaccinated. I don't expect the immunity to be lifelong, and I certainly think that in patients with Waldenstrom's or other lymphoproliferative disorders, the immunity is going to be less and actually shorter in duration. And so that's really the important wild card that we don't know in all this. With that being said, the vaccine is incredibly potent. I put this up here. This is actually the Pfizer vaccine. And you can see here that this is days after the first dose. And this here is the placebo arm, and this here is the vaccine arm. So here we are at day 14 where the curves are really split. And interestingly, this is before the second dose. So this really is that 2 weeks it takes until you mount an IgG antibody. And you can see here that there were very, very few cases of COVID in the patients who got placebo through day 100. And I really find this very impressive because this is an incredibly potent vaccine. When they talk about it being 95% effective, it basically includes this here. If you were to say, what about starting on day 14, when we think the vaccines worked, you're actually talking about an efficacy that's going to be approaching 99%. So it really is very potent. I'm actually very excited by this. The ultimate question is this is done in healthy adults. Whether or not these data will be replicated in patients with Waldenstrom's is unknown. The biggest thing, and this is the thing that I think is really the most important take-home message, is the endpoint is actually clinical infection, not antibody response or not a T-cell response. So it's not, we can't measure a blood test to say, yes, you're immune. It's not like what we have with the measles and the mumps and rubella. It's really based upon the clinical grounds right now. So we can't measure people's blood and say, oh, you're okay. Likewise, when it comes to proving this vaccine effective in Waldenstrom's patients, we would need to have 40,000 Waldenstrom's patients to be randomized to do this study again, right? So this was 20,000 patients randomized to each arm. And of course, 40,000 Waldenstrom's patients would probably be every single Waldenstrom's patient in most of the Western world. All right, so with that, I'd like to take whatever questions you may have.
That was wonderful. Thank you so much, Dr. Furman. And that last slide I've never seen before. That was fascinating. And I can't believe that data. So that's just amazing. Thank you so much for enlightening us all. Would you like to tackle, we have about 20 questions, and we've got understanding the new treatment questions versus BTK inhibitors versus COVID. What would you like us to start with?
Whatever you want to. It's your show.
Yeah. So let's see. Since you ended with COVID, why don't we just do a couple of those, if that's okay with you?
Sure.
Because we're in the zone there. Is the COVID vaccine safe for those with WM? And I think you answered. Do you recommend getting vaccinated as soon as possible? Which is really the question that I would love for you to speak to, because obviously folks are going to be listening to this carefully.
Yeah, absolutely. I mean, I think ultimately we don't know how effective the vaccine is in Waldenstrom's patients, but it is a potent vaccine, and it really is a safe vaccine. And I think one of the things that people often forget is that, the flu vaccine has a rate of ITP and a rate of complications that's probably actually worse than what we see with COVID. But because we're vaccinating millions and millions of people with this vaccine, you're going to see these episodes happening. So I do recommend the vaccine for everyone. I do believe the vaccine is safe. Even the J&J vaccine, which is technically using a live virus, isn't really a live virus. So it's what we call a replicant deficient virus. And so the virus, will carry the DNA into the cell, and that DNA or the RNA actually will then be made into protein that will then go ahead and present to the immune system and enable the immune system to mount a response. With the Pfizer and Moderna vaccines, they have the actual RNA in basically a fat globule. and it gets into the cells, but just, basically merging with the cell itself. So even though it's a live virus, the virus is just a transporter, and it's absolutely not going to be an issue with giving it to Waldenstrom's patients.
Okay. We have a couple of questions coming in the chat box. So about this, one is someone's COVID antibody test came back negative 5 weeks after being fully vaccinated. Does this mean he has not developed the antibodies?
It means that he has not developed the antibody. It doesn't
Okay.
mean that he's not protected, though.
Okay.
So that's an important difference. One of the problems is that if you were infected with the coronavirus that causes the common cold, you will have COVID antibodies in you. So the antibodies themselves are not specific to COVID-19. Many of them are actually just to all coronaviruses. But when someone's vaccinated and you have antibodies, and we can assume those antibodies against the COVID virus, we don't know whether or not the antibodies themselves are absolutely necessary to prove someone's actually protected, because you may actually have protection without having the antibodies.
I see.
The
Okay.
immune system actually is a T cell component and a B cell component, and we don't even know if we're measuring the important antibodies. So it really can sort of work both ways. Important component is, we have two passive immunization protocols where we actually give patients monoclonal antibodies that are directed against COVID, and there's the Lilly and the Regeneron. That's sort of the idea, like, you're going to take a while to make antibodies, so we'll give you some right now. If the antibody itself was really all that was necessary, then these drugs would be perfect and the only thing that we would need for COVID. Unfortunately, these antibodies have not been as effective as we would hope. I mean, they're effective, but they're not blockbusters.
Mm,
And so that's sort of one of the things that we're actually struggling with.
okay. A lot of questions are coming in now about whether you can, is it okay to continue Btk inhibitors when getting the vaccine, or should you hold it for a day or two, and what to do when you're getting vaccinated, and, Venetoclax and Btk inhibitors?
So interestingly, I do believe BTK inhibitors have a greater impact on the immune system function than BCL2 inhibitors do. We don't have any data specifically with regard to COVID. We've started to look at BTK inhibitors in different vaccinations in CLL patients, who, by the way, have lousy immune systems to start.
Yeah,
right. The important component, or the important part of the answer to your question, is that holding a BTK inhibitor for a couple of days or a week is not going to make a difference in the immune system. And so if you really wanted to give yourself the best shot of responding to a vaccine, you'd really have to hold it for much, much longer, probably in the order of 6 months. And then, of course, the relapse of the Waldenstroms would also have a deleterious impact on your ability to respond. So I really think it's better just to stay on the treatment, because you're on the treatment because you need it, and then just hope that you're still able to respond to the vaccine adequately. We've studied the BTK inhibitors in actually COVID disease, and while the only data we have so far is for Acalabrutinib, and that study was a negative study, I'm actually not so convinced the study was negative just because it was an impossible study to do. I mean, I can tell you in my experience, I have a tremendous number of patients on BTK inhibitors who have gotten COVID, and I've not lost a single one, knock on wood. Wow. So I actually, do recommend continuing BTK inhibitors in my patients if they do get infected with COVID. It's sort of the idea that I wouldn't stop them in preparation for a vaccination.
That's so helpful, Dr. Furman. Thank you so much for clarifying that. So many people had that question. And once WM patients have been vaccinated against COVID, can you tell us a little bit about what life is like? Is it safe to be close to people who've not been vaccinated? Any do's and don'ts that you want to give folks?
Oh, I don't think you want my answer to that.
No, we really do.
This is probably the most disappointing answer that we can all imagine for. I mean, we just don't know ultimately, but
Right.
I do think everything does need to continue as it has all along, that we still need to socially distance and wear masks and continue everything. The real mark of when it's going to be safe to resume some normalcy is when the incidence of new infections drops low enough that the likelihood of you entering a room with someone else with the infection is going to be low enough that the probability is that it's safe. So
Yeah.
that's really the ultimate issue, because we can't guarantee, we don't yet are able to say that that person who's vaccinated who won't get sick, because we know the vaccine prevents illness, can't still carry the virus and transmit it to others. And we don't know if you as a Waldenstrom's patients, will have responded adequately to protect yourself.
Okay.
And so with
That's
that in
very
mind,
helpful.
yeah, I do unfortunately recommend, until the governor gives the all clear, it's business as usual.
I'm really glad that you stated that, because it is hard news to hear, but it's so important for us because people are getting a little bit of pandemic fatigue, and telling folks that they got to just hang on a little bit tighter, vaccine or no vaccine, we have to stay safe and we have to take care of ourselves, first and foremost, is such an important message. So thank you for your clarity on that. And maybe I'll ask you one more about COVID, and then we'll jump to BTK inhibitors. I'm watching the clock, and I know
don't worry about the clock. I've got
so many
time.
questions for you.
But let me just say that,
generous.
Do you remember in New York City, we had the incidence of COVID so low in May and June just by using masks. And so, yes, the vaccine is excellent, but, if we were to get enough people to follow protocols, we really can get this addressed. And that's the thing that I really have to remark on.
Interesting. If you have next to no IgA or IgG, which is many of us on this call, but also in all of our groups, is the COVID vaccine still recommended? And is there any risk that we should know about?
So the COVID vaccine is recommended for everyone. We don't.
Great. Thank you for reiterating.
Yeah, we don't have any data, basically associating responsiveness to Ig levels whatsoever. We have a lot of data in CLL that proves that the IgG level itself doesn't really correspond to immune function. So I do think the IgG is a good measure of immune function, but having a low IgG doesn't mean you're not going to respond. And having, I think IgA is probably irrelevant in a lot of regards, but the IgG is sort of the important measure. And so that's sort of, so yes, everyone should get it. I think the worst case scenario is you don't respond, and the best case scenario is it saves your life. Yeah,
exactly. Okay, that's super helpful. Let's move on to BTK inhibitors, and then if there's time, we'll loop back because there are a couple of more questions about COVID. When a BTK inhibitor stops working for a patient, and this is going to be a theme, so get ready.
Okay.
Has the pathway become untargetable, meaning useless? Can you tell us a little bit about that? And then maybe I should just put this together with, in the case of a patient relapsing on a BTK inhibitor such as ibrutinib, what current options do you believe are most likely to promote good disease control with low risk? So lots of questions about what happens when, and these are real, because people are having it happen to themselves, and people in their groups for sure. We hear a lot of talk about it on IWMF Connect. What happens when, things stop working?
So, it's important to recognize that the B cell receptor pathway is very different than just the BTK inhibitors. So if a patient is developing progression on a BTK inhibitor, they still will respond to a PI3 kinase inhibitor. So the B cell receptor pathway itself isn't of no use, but of course, because ibrutinib, acalabrutinib, and zanubrutinib all bind to that same cysteine in the Btk pocket and work identically, if one of them is not going to work, none of them is going to work. So you can't go from ibrutinib to acalabrutinib to zanubrutinib. But the hope is RQL531, ARQ531, or LOXO305, because they work differently, they can actually still inhibit BTK even when the covalent inhibitors don't work. The problem is, though, is that the most common source of resistance is the development of a mutation that changes that cysteine that ibrutinib and acalabrutinib and zanubrutinib need to bind to. So LOXO305 will work if that cysteine's not there. The problem is if your mechanism of resistance is a bypass pathway, meaning the cell's upregulated some other enzyme that makes that enables it to work or live without the BTK pathway, then LOXO won't work. So it's not yet clear really, whether or not our newer agents, like the reversible BTK inhibitors, can be used in BTK resistant cases, but that is one hope. But certainly the other B cell receptor pathway targets are available. I actually also believe that, a lot of these BTK inhibitors will still have some activity, but just lose, a lot of it. So often, first off, Venetoclax will absolutely be effective in a patient who's progressing on a BTK inhibitor. And you sometimes may still get some added bonus or benefit by combining the BTK inhibitor with Venetoclax. Now, and that's something that we've done a lot in CLL already, and we've started to do it in Waldenstrom's. So combining the Bcr antagonist with the BCL2 inhibitor. But also, the PI3 kinase inhibitors, the anti-CD20s, all of those really can still play a role. Now, we haven't really talked about the anti-CD20s, so rituximab and ofatumumab. All these molecules really are meant to be, until progression. And, the study with Venetoclax was just 24 months of Venetoclax. But, the truth is you stop the Venetoclax, people progress, and then you put them back on Venetoclax and they respond again. So, ultimately, I think all of these pills people will take indefinitely until they progress. The rituximab and ofatumumab do afford sort of a fixed duration of treatment. That's nice. But, of course, being intravenous and having its impact on the immune system function definitely are sort of the downsides to that. But I just want to raise the two that, they're both still effective options. They've been tried and true. I tend to use ofatumumab because you don't get a tumor flare with ofatumumab that you get with rituximab. But I think, overall that they're still tried and true. With COVID, I think we have another reason to avoid an anti-CD20 because of the potential impact on your immune system response.
Okay, very helpful. This is moving in a slightly different direction. Do you know of is financial assistance from pharma and nonprofits available for acalabrutinib, zanubrutinib, or Venetoclax? I'm not sure if that's a fair question to throw at you, but
it is actually, because I think so. I think that there's a tremendous amount of financial assistance, and some of the financial assistance is regulated, but a lot isn't. Unfortunately, and this is something that I've tried writing on a couple of times. Medicare recipients have different rules to follow than those who have commercial insurance. And this has been one of the most frustrating aspects of it all. So a lot of the companies will have basically copay assistance programs that they can give to people whose balance of the drug is not being paid for by a government agency. So if Medicare is paying your 80% and then you're stuck with the 20%, and Medicare will pay 80% of any drug, right? Ibrutinib, acalabrutinib, or zanubrutinib. The question is who's going to cover the other 20%? And, if you were to talk to Beijing, they'd be very happy to say, we'll give you $2,000 to cover your copay. And if you have Aetna, Aetna's not going to say anything and you'll be okay. The problem is the federal government's going to tell you that that's a kickback and you're not allowed to do it.
Okay.
So it's sort of that issue that really runs a problem most of the time. So a lot of times I've been able to get patients free drug because it's not approved, and we've been able to go that route saying it's not approved, but we still want to use it. And so I've been able to, even though a patient might have like a 20% copay with ibrutinib, I have been able to get zanubrutinib as a free drug. And so there's ways to do it that way through the pharmaceutical companies.
Oh, wonderful.
a lot of the pharmaceutical companies do have also copay assistance programs, but that's going to really depend a lot upon the insurance and financial need. So, but outside of, that system, there's still other avenues like Leukemia Lymphoma Society and the LLS will have copay assistance programs and so forth. So there are a lot. And I think, having a lot of physicians, unfortunately, it becomes too laborious to really investigate everything. And I'm fortunate in the fact that we have a person whose sole job is to investigate all the different avenues.
Yeah.
And it really, I think, enables us to get drug for patients where, other physicians who don't have the resources are able to. So there is a lot of advantages to, making sure, you've exhausted all possibilities. Because I do think there's a lot out there to take advantage of. And
that's very helpful.
Yeah, and the person who's in private practice that has, one Waldenstrom's patient won't be familiar with all the different loopholes.
Right. Yeah. This is why I'm saying a day trip is a good thing. I have 2 more questions with ibrutinib and venetoclax. Well, we'll stay on that theme. Do you have any tips for getting insurance coverage with combination of targeted therapies such as ibrutinib and venetoclax? So someone was on this protocol and the coverage for the venetoclax was denied in combination with ibrutinib, which is interesting.
So sometimes one is, once you have a denial from insurance, you can often get free drug, and that's something that's really important. So often just having a denial is a good thing because the companies are able to provide free drug to people who do have denials. It's actually harder to provide free drug to someone who has insurance coverage because then it's, that's when they run into trouble regulatory wise. But in terms of a patient who I want to treat with both, I've actually, gotten one and then a couple of months later applied for the other. And sometimes the insurance company has a very short memory and has approved the second one. Not even, maybe they think the second one is, because they progressed in the first one and they never put 2 and 2 together. I've gotten lucky. And so I do, there's no harm in trying.
Yeah. Okay, that's very helpful. And if someone has failed on ibrutinib and then started venetoclax, should venetoclax be combined with acalabrutinib or Loxo based on what you were saying earlier today?
So I think really I have to emphasize that if a person progresses on ibrutinib, acalabrutinib will not work. So, Loxo is very different in the sense that it might overcome some mechanisms of resistance to ibrutinib, acalabrutinib, and zanubrutinib. But from an efficacy standpoint, ibrutinib, acalabrutinib, and zanubrutinib are really interchangeable. Now, there's some interesting differences. So ibrutinib and zanubrutinib and acalabrutinib have different drug-drug interactions, and acalabrutinib has the issue where if you're on a proton pump inhibitor like Prevacid or Protonix or Nexium, you might not absorb it. So I've had patients who stopped responding to acalabrutinib, we all of a sudden find out that they've been taking accidentally a proton pump inhibitor. And so getting them off the proton pump inhibitor allows them to respond again. But I also have patients who, need to go on a proton pump inhibitor. So I switch them to zanubrutinib or ibrutinib and they're fine.
Okay,
so
cool.
By and large, if it's really true progression, you can't substitute ibrutinib, acalabrutinib, and zanubrutinib from one another.
Okay.
There is some benefit of synergy. So if someone's progressing on ibrutinib, adding venetoclax may be more efficacious. And we definitely see that in CLL, and we're waiting to show that in Waldenstrom's. But in essence, whether or not you stay on the ibrutinib or add acalabrutinib or zanubrutinib is 6 of one, half dozen of another.
Okay, very helpful. What I'm thinking, doctor, is with your permission, I'd love to move on, talk a little bit about novel treatments, because we've got a whole bunch of questions, because folks know that's one in your wheelhouse. And then what we might want to do is jump to the chat after that, because, like I said, exploding with questions when everybody heard that you were coming. So we really wanted this kind of fireside chat feel, and are so grateful to you for giving us some extra time so that we can achieve that. Thank you for your generosity and graciousness. We really appreciate it. If anybody needs a stretch break, go take it. We understand. We'll be right here waiting for you when you get back. One question, when do you expect tirabrutinib will be available in the USA? And I don't know if it's tirabrutinib or tirabrutinib, so I'm sorry about the pronunciation.
So actually, I don't know either. I don't think tirabrutinib is really going to add anything. I think it really is just, it's the fourth one in the series of covalent modifiers.
Okay. Nothing too major. Okay.
And
So
the truth is it's sort of, Gilead has a long track record of ruining good drugs.
Okay, that's great. We're going to quote you on that.
Yes. I long ago burned my bridges at Gilead.
Clearly. And if you didn't, then we did now. So what are the up and coming treatments for WM, and are you likely to prescribe them?
So I really think, BTK inhibitors really represent our best choice. I do think that, Venetoclax has a tremendous role as well. We've actually been, so interestingly, I can tell you from what we have here, daratumumab, which is an antibody against CD38, the Dana-Farber has completed their study, and it preliminarily doesn't look positive, meaning that it doesn't look effective by itself.
Right.
Don't quote me on that because I don't get in trouble. But we are still looking at it in combination with BTK inhibitor therapy. If the cells are sort of in stasis, might the CD38 antibody have a role to play? So that's one option. The other options is we have a couple of new BCL2 inhibitors that I think might actually play a role as well. Ultimately, I suspect, and I also actually like the PI3 kinase inhibitors. So, duvelisib and idelalisib are both very, very effective in Waldenstrom's patients. And I've had, I've had a large number of patients who really have had great responses. The biggest problem with duvelisib and idelalisib is people develop some autoimmune sequelae. So they can develop colitis or pneumonitis or rash. Umbralisib just got approved 4 weeks ago in marginal zone lymphoma, and it's a PI3 kinase inhibitor that is effective in Waldenstrom's. It doesn't have the autoimmune sequelae. So I'm very interested to see whether or not that would be a great option for patients as well, long term. So I am also very interested in those. Other non-clinical trial agents that I use, I often use, like Nalaro or carfilzomib, as I mentioned, which are the second generation proteasome inhibitors. Someone had mentioned the CL, I'm actually blanking, 191.
Yeah, CLR 131.
131. There are a lot of different things that are being investigated. And I think it's always very important to recognize how these drugs sort of try to get a foothold. I think, right now, my bias is combining drugs that we currently have that we know are effective are likely to be sort of the next step forward. So, BTK inhibitors and Venetoclax, or PI3 kinase inhibitors and BCL2 inhibitors, those I think are likely going to be the next instead of some of these other ones. So one of the problems with 131, is that it is radioactivity. And it does, yes, it had a very high response rate in a very small number of Waldenstrom's patients in the phase 1, but a lot of these patients had a lot of marrow toxicity afterwards. And so I don't see it as an option for most Waldenstrom's patients unless you're going to a allogeneic bone marrow transplant. So I'm very cautious, I'm very adverse risk averse, right? So, I really do believe trying to avoid risks. The one thing I don't want to do is have the treatment worsen the disease.
Right.
And so I do think that that's a problem with a lot of the different treatments that people have. I do find bendamustine as sort of, the one chemotherapy agent that I will use because it is something that I hope will be safe long-term. And it so far looks like it is. But I do try to avoid chemotherapy. Other than that, there's, a couple of high-dose steroid protocols, which I do use as well, which I think are well tolerated by and large, and they do seem to work very effectively. Whether or not in COVID that's really a great idea right now is a separate issue. That does something that, does come to mind.
Right. And now a little bit into the world of CLL. What differentiates a CLL diagnosis from a WM diagnosis? How do you know which of these two B-cell lymphomas the patient has?
So going back to the slide that I originally showed with the bone marrow and the diagnostic criteria, what's really important is morphologically, when you're looking at the bone marrow or the lymph node sample, in CLL, you'll just see identical lymphocytes, small lymphocytes, one after the other. In Waldenstrom's, you'll see a small lymphocyte, and then you'll see a plasmacytoid lymphocyte, and then you'll see a plasma cell. So, this combination of the three of them together is really what's classic. So morphologically, they look different. They do have different proteins on the surface. So the CD markers, or the cluster differentiation markers on a CLL cell, will be CD5, CD19 and 20, and CD23. On a Waldenstrom's patient, you're going to not have CD19 or CD23, but you'll have CD19. You won't have CD5 and CD23, but you'll have CD19 and 20. So it's that sort of difference that really tells us molecularly whether or not these are the same or not. There's a lot of information out there about Myd-88 and whether or not that plays a role. Importantly, it's not diagnostic. It is prognostic in terms of predicting response to ibrutinib, but it's not diagnostic. And the diagnosis is currently based upon really the morphology and the immunophenotype of the cells themselves. And that's really an important thing to emphasize.
This is a question that came in just this week, and it's about Myd-88. So I want to ask it to you, although I'm not even sure I fully understand. What are your thoughts about inhibiting Myd-88 versus the downstream signaling?
So Myd-88 is very upstream in the B-cell receptor pathway. I'm very happy to inhibit anything that works. Right now we have a lot of data supporting BTK inhibition and PI3 kinase inhibition. We don't have any data supporting Myd-88 inhibition. As I mentioned, before 2009, I have a collection of about 20 different molecules that I investigated. All worked very nicely in the lab, none of which worked in the clinic. So that, the proof is always in the pudding. Yes, Myd-88 inhibition works very nicely in the lab. Whether or not it works in the clinic is the million-dollar question.
Okay.
So if it works, I'd love to use it.
I love that. And how does one know when they are relapsing? What lab value changes are significant?
So the thing I think that makes Waldenstrom's a little bit easier to follow is because of this IgM as a marker of the disease. So the way to think about it is every Waldenstrom cell will make X amount of IgM molecules. And so you can see that IgM floating in the blood. Now, if someone gets treated and their number of cells goes from, let's say, 1 billion down to 100,000, that 100,000 will have a relatively steady rate of IgM production. The IgM, in the 100,000 is low enough that you won't have low blood counts or a big spleen, but you'll still see an IgM in the blood. And as that 100,000 grows back to 200,000, you'll see a rise in the IgM. And so that IgM is going to be the first measure of someone actually relapsing. So, a huge caveat to keep in mind is that the IgM is sort of hard to measure, and there is a lot of variability test to test. So one is I never act off of one test result. And two is, I really look for a significant change. So I have a patient whose IgM's gone from, 900 to 1200 and back to 900 on ibrutinib for the last 5 years.
Yeah.
Right? To qualify formally as progression, you need to have a 50% increase in the IgM. But, you hear this person's having a 30% increase in the IgM, but it's just the next measure, it's going down. So we ask not only for a 50% increase, but it has to be repeated on subsequent measures. And that I think is really more just because of the IgM, the variability in measuring it, and the fact that, there could be, a recent infection or something that might have caused an acute rise in it.
So interesting. Dr. Furman, this is so interesting. Thank you for teaching us so much. I have 4 more questions here, and then I wanted to invite you to hop over with me to the chat, and you can pick whatever out of there you want to do, because we're so grateful for your time, and we are coming up to the end of our meeting. But if folks want to hang around for a few more minutes, I think we're going to get to everything, which is amazing because of your generosity. What red flag markers in WM do you prioritize for changing the course of treatment when disease progression is beginning?
So it's really just the IgM that's going to be the most important. And yeah, I think, a lot of the, most people, the height of the IgM is going to be the most important driver of treatment. Some people who have neuropathy or have, basically an issue with a vasculitis, might see symptoms develop before the IgM significantly budges. And that's sort of a very different scenario. It's interesting. We, for so long, have had these Igm associated neuropathies, and typically, the anti-myelin associated glycoprotein antibody, which is the most common antibody to cause neuropathy, really is a very poorly advid antibody. And so what we find is that, if you have a titer of, more than 90,000, you'll start to have symptoms. And if the titer is below 50,000, it's unlikely to have symptoms. But I've found a few people who have, myelin-associated glycoprotein antibody-induced neuropathy with titers that are actually 1,000. And it's all the difference is sort of the avidity of the antibody. So, it's always, always important to be prepared and assess and think about everything. And a lot of that's going to drive sort of what is also the target of treatment. So normally if a patient has neuropathy and their IgM is 5,000, getting them down to 2,000 is probably more than adequate to keep them from having neuropathy. If a patient has neuropathy at 7,000, they might only need to get down to 3,000. And so, these are sort of things that drive sort of how aggressive we need to treat and what we need to do. As I mentioned earlier, I don't know if there's any downside to leaving someone with an IgM of 2,000. I mean, as far as we know right now, there isn't. And, above all else, do no harm. So we do like to not intervene unless it's really necessary.
Right. Critical. That's critical. Why do, this is a one that I know is on many people's minds. Why do the WM cells sometimes wander from the marrow into the CNS, the pleura, the bones, et cetera? Can you speak to us about that? Because we hear a lot about mutations. And
yeah, so it really has nothing to do with mutations. First off, they don't wander into the bones. Remember, they live in the bones from the outset, right? The bones and the bone marrow are really the same compartment. I think that's very, very important. The CNS, or the central nervous system, is what everyone calls Big Neal. And we talk about it a lot. As it turns out, Big Neal was described before Waldenstrom's was described. So he's got a kick out of that. Yeah, so when the guy described Big Neal syndrome, he didn't know what Waldenstrom's was.
Oh, wow.
Big Neal is very, very rare. And it's something that does require a different treatment because a lot of our treatments don't penetrate the central nervous system. And that's really why it's important to make that distinction. In terms of wandering to other spaces like the pleura, I mean, that's incredibly rare. And I think one of the things that I often get consulted on is I'll have a patient who has Waldenstrom's and has a liver biopsy and they find Waldenstrom cells. And let's say, oh, the Waldenstrom cells is causing the liver abnormality. And the answer is probably not, that the Waldenstrom cells are just everywhere. And so they're just hanging out, and that they're not really damaging the liver. And so it's always important to sort of keep that in mind. Now that's very different in the pleura and the CNS, but it is important to sort of, keep that in mind. I mean, the pleura basically is contiguous with the lymphatic drainage. And so having a few cells in there is not a big deal. It's really a question as to whether or not the cells themselves are causing an abnormality or a pathological process.
Mm-hmm. Wow. That is a really interesting, thank you. That was a fascinating answer, and one that I know a lot of people are going to benefit from. That's really eye-opening. What is one new clinical trial that you would like to see research on? Is there something that's in the wings that you're?
I really think probably the one that I really am anxious for is to see, zanubrutinib venetoclax combination therapy.
Oh,
So you
good.
can imagine
Really?
what we're working on. Yeah.
Good to hear that. And then we have a very specific question about bendamustine Rituxan, and you can choose to answer this or not, but when treating with bendamustine and Rituxan, Ritux is often withheld for the first round or two to prevent possible IgM flares, as you know. So the person is asking said that they've heard of cases where they're still being used together for the very first treatment, and they're wondering what type of procedure can a patient expect to mitigate the IgM flare should it occur. They have patients in their group who are going through this and wondering, a little bit scared, how do you begin up with that first round, knowing the risk?
The truth is the bendamustine in part will mitigate the IgM flare, by sort of immediately destroying the cells. The problem is, what happens if the bendamustine doesn't work as well as you hoped, and so that you end up with the flare. The biggest downside to the flare is just having to do plasmapheresis. So one would argue doing plasmapheresis prophylactically is the same thing as just doing it if necessary, and just, potentially less likely to be done prophylactically. But I do believe, avoiding the rituximab in the first cycle is probably a great idea because of the risk of tumor flare. And, once again, it's unclear how much the rituximab might add. But if the rituximab does add, which I actually do think it does, missing one cycle is certainly not going to put a patient at a disadvantage. And so it really is enabling effective therapy to be delivered safely.
Right, that's very helpful. One last question as we hop to the chat box, and we're just coming up on 4 o'clock. So friends, we've got through all the questions that you submitted after I asked this one, and the chat boxes are the ones that just came in today. So if you do have to run, we understand, but Dr. Furman is generously you're going to be here to what, 2 or 3 in the morning? You're fine with that? No problem? That's not a problem for you? No, we'll be skedaddling along here, but this is the most important thing I want you to answer.
Listen, I have nowhere to go. It's COVID.
Are you available to consult with WM patients via telehealth or in person? And would you like to tell us a little bit how people who might be interested could go about contact? We have you on the IWMF Physicians Director. As you all know, the directory is full of WM experts nationwide, and of course, Dr. Furman is one of those in New York. So you can get his contact information there.
One of the benefits of COVID is, previously there was these rules governing, medical licensing was state by state.
Right.
So I could be in New York and, I can't really practice medicine in the state of Pennsylvania. So if a patient were in Pennsylvania, that would be illegal. So one of the things that happened with COVID is they did away with that law, or 46 out of the 50 states waived that. So in essence, now I can do, visits with people in almost any state. And so, yes, so I do telehealth. The goal, of course, of that waiver was to actually enable physicians to, come to New York to help with the pandemic initially without having to get relicensed.
Oh, wow.
But this has also been something we've done. So in essence, I've been able to do video visits to keep patients away from the waiting room, right? So we do that to lower our influx of patients at one site. But it does sort of enable people to, from California to do a consult with me without having to actually travel here.
Yeah.
And so all you need to do is actually just schedule an appointment, and you just request a video visit, and it's as simple as that, and forward the records. And so it is one of the benefits because it enables people in remote locations to get specialty care. And I really applaud it, and I hope it doesn't go away when COVID does. And it will go away. I just want all of you to realize that. It will go away.
Really?
COVID will go away. I hope the regulation doesn't go away.
Oh, I thought you meant the regulation was, okay.
No, I hope COVID will go away sooner or later. I hope the regulation that allows us to do this doesn't go away, because it's a way to, for people with rare conditions to get care still.
Okay. A non-COVID question here. Do you expect bone marrow appearance on an MRI to improve more with time when on a BTK inhibitor? If labs are improving, but the marrow is supposed to be tracking, but is the marrow supposed to be tracking with it? And if so, how slowly, quickly is it expected to improve? I get so many questions about this on Lifeline, people calling and wanting to know about the significance of bone marrow infiltration, what it means, you know, and
would just ignore it. I mean, the truth is the MRI is so far less sensitive than everything else. And, you know, the truth is, you know, your bone marrow has the ability to expand. And, you know, in adult humans, most of the bone marrow is going to be in the breastbone, the vertebral bodies, and the pelvis. But if your marrow fills up with Waldenstrom cells, your body will adapt and start having bone marrow cells in the ribs and in the skull and different areas. You know, it's not clear that as you clear out the marrow, it necessarily reverts, right? Like you'll still have some marrow going on in all those locations. And it's also, you know, even if the marrow does revert, it's not going to look the same as it always did on MRI. So I really wouldn't I wouldn't be concerned about the MRI findings at all, and would really only follow the laboratory abnormalities.
Okay. And we have a question that's complicated. So Julianne, I'm going to ask you to step in here because you might have to help me out here. But she wanted to ask about the Alexis SARS-CoV-2 antibody S spike bold test offered from Beijing through Roche. Are their results not meaningful? And I'm not up on that to know enough about to help you. You're on your own, in other words.
So when you say not meaningful, you know, the problem is that, you know, the question is what's meaningful? Is it in terms of protection against getting sick, or is it protection against getting infected, or is it just serving as a marker of being exposed? And then, of course, the question is it exposed to COVID-19 or is it exposure to any coronavirus? So it really depends on sort of which aspect about that you're really most interested in. I mean, the problem is, you know, we don't have any data regarding the ability of these tests to predict protection. And so that's sort of the problem. I mean, the important aspect of the clinical trial is it used actually clinical endpoints. So we know our endpoints are the most important and meaningful. We don't have these correlates because, you know, obviously to test serum on, or to do nasal swabs on, you know, 40,000 people on a weekly schedule was just, you know, not doable. Right. But that's why we say, you know, thank goodness we still have the clinical meaningful endpoint, which is we don't see illness.
Yeah.
So it's more an exploratory thing that we're just trying to find out what does happen, that Dana-Farber is asking their folks to send something in 3 and then 6 months afterwards. They're just curious. They just want to see.
We were very interested in collecting any and all data, right? So where, you know, everyone's collecting, you know, serum and testing for the antibody titers. I have to tell you that in my patients who have I've had a lot of patients not develop antibodies with the vaccine, and I've had a lot of patients actually get infected, have antibodies that then go away. You know, these are helpful, important data to collect. You know, who knows what we may find. You know, the greatest limitation, of course, is that most of these studies will require large numbers of antibodies, a large number of patients.
Patients, yeah. You need some controls, you need some infected, some not infected, some.
But you'll never have enough infected, hopefully.
Yes.
Right.
Yeah.
Right. Yeah. Well, let's see if we can't wrap up by 4:15, Doctor, because I certainly don't want to keep you too long. And we do have I'll give you 2 questions, and then you can see what we've got. A question about what's the best way to treat and manage wild type WM, and then what about CAR T for WM?
Yeah, so let me say that, you know, one of the things that's interesting about the wild type, you know, Myd-88 and CXC4 and all these mutations, you know, the responses are definitely less, you know, I mean, the mutational status predicts response to Btk inhibitors. And, you know, right now the data is just for ibrutinib, but I think it's a safe assumption that the data will be extrapolatable to all of them. I think the truth is that there still is a response rate with Btk inhibitor in, you know, the patients who are predicted to do the worst. So it's still worth trying if you think they're good candidates for Btk inhibitors. I wouldn't deprive someone a chance to respond because the response rate's not 100%, right? Like the response rate might be only 60%, but it's still worth trying. It's not zero. You know, I think the CAR T cell question is a much more different one because, you know, there are a lot of toxicities to CAR T cells, and we currently don't have any data that they're effective. So right now, CAR T cells for Waldenstrom should only be part of a clinical trial. I am risk adverse, and, you know, I do find CAR T cells to be, you know, very risky at times. So I have always had a bias against them. And I've used it actually very infrequently in my CLL patients as well.
Okay. Are there any particular treatments that are more effective for extramedullary lesions?
So it's interesting. I mean, the answer is none of them really have been, I mean, so the classic one is if you're going to consider lymphadenopathy extramedullary, the answer is, you know, BTK inhibitors are incredibly effective in lymph node disease. Probably more so than the BTK inhibitors are more so than the BCL2 inhibitors. But by and large, all of these really probably work, you know, equally. I mean, the disease, except for BTK inhibitors, is a little bit more less responsive outside of the bone marrow than it is inside. And so the BTK inhibitors may just have, there'd be the one advantage there.
Okay. And now just an interesting question. I thought, OFA, and I'm going to have trouble with, but I usually call it OFA and I failed on it, but ofatumumab had fallen out of favor. Do you prefer it over obinutuzumab?
So yeah, so ofatumumab, I can't really say it fell out of favor because I don't know if it was really ever in favor. You know, I was very involved in the ofatumumab pivotal studies for CLL. And, you know, I do find ofatumumab to be less effective than rituximab. And I think Waldenstrom's, it's different because this tumor flare issue really is an issue, and we don't see that with ofatumumab. So I do use ofatumumab preferentially in my Waldenstrom's patients over rituximab. You know, the one thing that I find very interesting with the anti-CD20 is you see very delayed responses. And I think that's very interesting. So you could see a patient really start to respond at month 12 and continue to improve, you know, at month 24. So it's very interesting looking at the anti-CD20 therapies. Obinutuzumab actually has not really been studied in Waldenstrom's, and I tend to, you know, it's really much harder to tolerate from an infusion perspective. And so I don't use obinutuzumab in my Waldenstrom's patients at all.
Yeah. Understandably. Okay, thank you. That's very helpful. And many of our members have very low white blood counts. Would it increase the risk to get the COVID vaccine? This is the last one we have on the COVID vaccine, but I wanted to ask because people are asking many different ways about risks of COVID, and I want you to, you know, if it's possible, to speak to any concerns you might have, because so far I've heard that you don't, you know, have that all WMers should really be getting the vaccine as soon as they possibly
so I have no
can.
concerns over the risks of the vaccine, and the
Thanks
vaccine risks
that.
itself really has nothing to do with the white count or any other parameters. A lot of the side effects of the vaccine are just stimulating the immune system. So arguably having side effects is a good thing.
Right.
You know, there are a few overexuberant immune responses like ITP, which would be dangerous, but fortunately those are extremely rare. And, you know, and I don't have any concerns with Waldenstrom's patients getting the vaccine, and I really, you know, can't think of a reason not to get it.
Thank you for stating that so clearly. What about when IVIG increases the IgM level and doesn't go down? Have you had experience with, you know?
So I get that question a lot. IVIG, which stands for intravenous immunoglobulins, is pooled human immunoglobulins, and it really is almost exclusively IgG. There's really, you know, very, very little IgM and IgA in there. And, you know, we actually have, you know, there are a lot of people who have allergic reactions to IgA if they're IgA deficient, and it's even rare to see enough IgA in the IVIG lots to actually even induce those issues. So I can honestly say that I have not seen and would never expect to see IVIG raise an IgM. The quick answer would also include, if you were concerned, you can just do an electrophoresis and see whether or not it's monoclonal IgM or not. Because if it's the IgM from the IVIG, it wouldn't be monoclonal. But there really is not a detectable amount of IgM in IVIG.
Okay, super helpful. And this is the grand last question. You've answered every single one of ours. I don't know how you did that. That's definitely record time, and it was so generous. But what treatment would you recommend if a WM patient develops hemolytic anemia? You mentioned during the presentation using some of the newer therapies. Were there any specific treatments that you wanted to speak to, or?
Yeah, so it really, and I'm not ducking the question, but it really depends on the type of hemolytic anemia. So there's really two broad categories of hemolytic anemias. The most common one that we see overall is what's called a warm autoimmune hemolytic anemia, where actually the normal B cells make autoantibodies against the red cells. And that's just due to the immune impairment that we see with these low-grade lymphomas. Those people do extremely well with rituximab. The people who have cold agglutinins or, a cold autoimmune hemolytic anemia, I often do try rituximab as well, but often those patients need something more. And I've actually used a lot of Btk inhibitors in those patients.
Interesting. Dr. Furman, thank you so much. This was so informative. We're so grateful for your time, your wonderful presence, and let's unmute and applaud. Thank you. We all represent international WMers, and we will happily spread the word. So join me in thanking Dr. Furman, not only for what he did today, but what he does every day on our behalf. Thank you. Thank you so much.
Thanks, Dr. Furman.
My pleasure.
We look forward to you coming back and meeting with the support group leaders again. We would love to learn from you again in the future. And we just wish you all the very best with all the tremendous work you're doing on our behalf. And we can't thank you enough for it.
Absolutely.